Hi everyone, thank you for coming today. My name is Melenik M and I am the public health intern here at the Maxwell and Eleanor Love Patient and Family Learning Center. Please be aware that Mass General will be live streaming and recording this for Mass General social media. We are trained in patient safety and privacy, and we will not be interfering with the presentation. And also, if you are not comfortable reading questions out loud, please feel free to place it in the basket back there and I would be happy to do so. So today, in observance of February being Go Right for Women and American Heart Month, today we have Dr. Esther Davis here. She is a clinical and research fellow in advanced echocardiography here at Mass General Hospital. She is here to give a talk on the important topic of heart issues among women. So please join me in welcoming Dr. Davis.
Thank you, and thank you everyone for braving this weather, although I am told is mild by Bostonian standards in February. I'm really privileged and pleased to have the opportunity to talk to you on this topic, which, without any pun intended, is very close to my heart. And I'm really grateful that so many of you have come. So I'm going to try not to break the technology while I do this, see how we go. I have no disclosures in relation to this talk, except that the accent is Australian, and I am from here, this little city, which is very far away from Sydney and Melbourne, the cities that most people know. My home city has fewer cardiologists in it than are in this building at this current second. So it's been a bit of a shock to the system working in Mass General, but I'm very grateful for the opportunity. However, people like this slide because people often don't know quite how large Australia actually is. So here I superimpose the continental United States. I like to use this to show when people ask me if I'm from near Sydney, that it's a bit more like being from Los Angeles compared to DC. Now, I thought we'd start with a video. This video is getting a little bit dated. It's been around for 10 years now, but it is still so relevant in terms of the way women experience heart disease. So if you'll bear with us while we change over to the player.
It started out like a totally normal day. Mom! Okay, move objection deadline to the third line after survey. Oh, honey. What are you doing down there? Did you finish your breakfast? Ow. Don't hit your brother. You have to eat something. Here. Okay, 5 minutes to carpool. Where's my coffee? You okay, Mom? Oh, I'm fine. Sandwich orders. What do you want? Almond butter and jelly. Okay. You sure you're okay? I'm fine, sweetie.
I'm so late. What are you doing? Connie? You okay?
Yeah, I'm fine.
You sure?
Oh, yeah. Here.
Acai, my favorite. See you guys later.
Wear your shoes. Put your shoes back on, please. You know, go help your sister. We're going in 3 minutes. Oh my God, what am I doing? I forgot to cut off the crust. Voila. Shoes on, potty if you need it. Get your sister. Okay, here. Nobody move. Getting a dustpan. Mom! I think you're having a heart attack.
Oh,
Turns out I was having a heart attack. Heart disease is the #1 killer of American women. So now I take care of my heart, and I tell the women in my life to do the same.
Sounds great, by the way.
That's nice, sweetie, but that's not my heart. That is. Make it your mission to save your life and the lives of the women you love. Find out more from the American Heart Association at goredforwomen.org.
And I think that video, while stylized, it captures a lot of things that are real about the way women experience heart disease. That feeling that it can't happen to me, and that, you know, the symptoms, even if in anyone else you would turn around and say, you are having a heart attack, women don't respond to that with, I am having a heart attack, for a number of reasons that I'm hoping to go into over the next little bit. So, heart disease is a big problem, and it's a big problem in women, and more women than men die of heart disease, and that's been the case for quite a long time. This is American data. I do have some Australian data that I've snuck in here, but this is US data, and it's shown that since about 1985, women's numbers of deaths have been greater, but we don't really know that. I worked it out this morning when I was getting ready for this talk. Heart disease kills 821 women every day in this country, which is a much more spectacular number than what I used to say back home, which was 32 women a day. Got a bit of a smaller population, but that number's overwhelming. And one of the big issues is women don't know this. It's improving, and things like the Go Red for Women's initiative have improved our knowledge that heart disease is an issue for us, but it's still not something that women understand on a population level. This is the heart disease death rate over the last few years across the country, and with some variability you can see that it is an issue that is nationwide, and women all over the country are dying at high rates of heart disease. It kills more women than cancers, respiratory diseases, and most of the other causes combined, but women will still tend to think that breast cancer is, you know, the big issue that they need to worry about over the course of their lifetime. It is an important issue, but heart disease is still affecting more of us on an ongoing basis. Like I said, women don't know this, and there's a lot of reasons for that, but this data looked at women, this is women specifically, across the years between 1997 and 2009. And there's been improvement. People do know more than they did before. Back in 97, only about 30% of women could identify that heart disease was the #1 killer of women. It's improved, it's sitting around 56% in 2009, but that's still a large number of the population that don't understand how this problem applies to women, and therefore don't realise that it's something they need to be thinking about for them and their family members. And there are some variations in the knowledge that people have depending on age and ethnicity. This study looked overall at the number of people who could identify heart disease as the #1 killer, which was 56%. People thought breast cancer and cancer in general quite prevalently, and that's very common across all populations surveyed. But there was some racial and ethnic variation, so slightly more Caucasian women could identify the fact that heart disease was the #1 killer in women, slightly less from Black and Hispanic populations. And we don't understand the reasons for this, and I think, you know, looking into like this in terms of disparities of understanding of disease is really important in this area and many other areas going forward. Age also plays a role. Young women, particularly unlikely, interestingly, to understand that heart disease is the #1 killer of women. That gets slightly improved with age. See if I can make this work. So in the 45 to 64-year-olds, about 62%, and then it drops off again. So over the age of 65, which is ironically the group of women who are experiencing the majority of these heart attacks, that knowledge drops off again. And this data has been carried out. So if you continue the data up to 2012, Again, there's still a substantial proportion of people who don't know about heart disease in women, and perhaps somewhat concerningly, it looks like in certain groups there might have even been a drop in awareness. So it's an ongoing battle. Even though the message is getting out there, we need to keep putting it at the front of people's minds. Didn't work. There's also differences in people's awareness of what the signs of a heart attack are and what they would do if they thought they were having a heart attack. Well, for me it seems obvious, but I'm a cardiologist, so I'm not an unbiased audience. But chest pain, clutching chest, falling down, I hope the media has portrayed enough heart attacks that most people might think of those as signs of heart disease. But only 56% of women surveyed identified that as a primary sign of a heart attack. So that is potentially concerning. What's also concerning is what people said they would do if they thought they were having a heart attack. And I thought this statistic was really, really interesting. So in these women, if they thought someone else was experiencing a heart attack, 81% would call 911 as the first go-to call. But if they thought they were experiencing a heart attack, only 65% of women would call 911. And I have a patient story, a video that's coming up that I think highlights some of these factors really importantly, and how this is a real world problem. And just to get my little plug in for Australian data, it's bad everywhere. This is not an isolated problem in the United States. So back in 2005, 97% of Australians did not know that heart disease killed Australian women. And some people thought it was prostate cancer, which concerns me greatly. There's a long way to go in terms of people's awareness. And this, I'm sorry, is a bit small, but this is a study from Australia that was published in 2017, so the data goes forward to 2015. And here, only 33% of women could identify that heart disease was the #1 killer of women in Australia, and only 19% of men. So only 26% of the overall population surveyed realised that heart disease was such a big issue. So I'm going to show this story. This is an Australian story from the Australian Heart Foundation of a woman who experienced heart disease. And a lot of the things she will express, and I'll let her talk in her own words, are things that are very common to the experience of heart disease in women, including those feelings that this couldn't happen to me, and the not wanting to call an ambulance. So I will let her speak.
I'm Esther, and I suffered from SCAD, which is a spontaneous coronary artery dissection. I was at an open for inspection in a house that we were looking at buying. I started to feel pain in my arm, in my left arm. The pain radiated sort of from my shoulder down into my arm, and I was hot and sweaty at the time, but didn't want to cause a scene because I was in a house with people I didn't know. Luckily, my husband arrived and sort of recognised the symptoms that maybe I was having some kind of heart problems. I begged him not to call the ambulance, but he persisted and phoned, and it was really lucky that he phoned when he did, because the ambulance team arrived, and within 3 minutes of them assessing me, I went into cardiac arrest. My heart stopped beating for over half an hour. The ambulance team performed CPR for 32 minutes. I had 7 defibrillation shocks. When the ambulance team arrived, they had to cut my clothes off me, put the defibrillator on, and I think they were expecting once they defibrillated me once I would come back to life, and that didn't happen. I turned blue and my eyes were bulging from all the compressions. I had several broken ribs and I didn't look in a great way. So my husband thought that he'd be telling his kids that, Mummy died today. I was taken to St Vincent's Hospital, rushed into emergency where they placed 3 stents in my heart, spent 6 weeks in hospital, and also had an ICD fitted before I left. The reason I had the heart attack and the cardiac arrest was because of SCADs, which is a really rare genetic problem that I have. I had no idea that I suffered from this prior to my heart attack. My LAD, which is the main artery in my heart, dissected, so it tore from top to bottom, leaving no healthy artery at all. I just presumed it wouldn't happen to me, and I always imagined that heart problems were for men over 60 who have carried a little bit of weight. I would never have thought that someone as healthy and as active as I was could or would suffer such a heart attack. Prior to my heart attack, I was really active, fit. I would run, swim. I've got 2 young children that I'm always running around with. Was working, a really busy, active, full-time mum. Never in a million years thought that I would have a heart attack. And I think that's why when my husband suggested call an ambulance, I would never have believed that I would have a heart attack, and not just a heart attack, a massive heart attack with a tear, cardiac arrest, 6 weeks in hospital. It never would have occurred to me. I do feel sorry for him. I think it was harder on the family than me, because I don't remember the event or ICUs. They're the ones that saw how sick I was, and having to hear the doctor's advice and prognosis was hard for them to take, I think. Each day I'm here is a blessing. It's another day I get to spend with my kids and my family and live my life. I definitely don't stress out as much as I used to. I'm not as busy as I used to be. Much calmer person. I'm strong. I think I've handled this really well. I was faced with a massive challenge, and I think I've got over it pretty well. I remember thinking in the beginning, no one is as sick as me, or I can't believe I've just been through this. And you do get better at dealing with it and stronger, both physically and mentally. And it's something that to educate yourself about, and I do feel now I'm on top of it. I feel like I'm slowly getting my life back.
So I think that brings up a lot of the issues. Couldn't believe it was happening to me, begged my husband not to call the ambulance. And although SCAD, which I'll discuss a bit in a moment, is a rare cause of heart attacks, it's not a rare cause of heart attacks in women, particularly young women. And so this story is not an isolated one, and it's up to all of us to educate women that it can and it does happen to them, so that they can seek out treatment. One of the issues in this field is that women don't necessarily experience heart attacks in the same way men do. A lot of our traditional thinking and knowledge about the typical symptoms of a heart attack comes from what men's typical presenting symptoms of a heart attack are. And so women who more commonly present with what we call atypical symptoms are less likely to associate that with the possibility or the idea that they might actually be experiencing heart disease. Most of us probably have some understanding, although maybe not given the data I've previously presented, but if you picture clasping chest, sweating, nauseous, fainting, that's kind of the classical picture of what having a heart attack looks like. Often in people's minds add into that a middle-aged, slightly overweight man, because that is how even doctors perceive this problem. Women are more likely to have atypical symptoms, things like dizziness or lightheadedness, stomach pain rather than chest pain, feelings of fatigue. And although a lot of these women do still have chest pain, in fact up to 90% of women will have chest pain in association with their heart attack, it may not be the dominant or the only symptom that they experience, and so the constellation won't necessarily get put together as fast in a woman as in a man. And women tend to seek help. Oh yes, my apologies.
My mother-in-law had a heart attack, and she said the pain in her jaw, she just wanted to rip her head off. It was so
Yes.
bad, and she thought it was just so weird because she went to the hospital, but she didn't know that was a sign. But
Yep.
she said she really just wanted to rip her head off.
And that's another common sign is jaw pain. And jaw pain that comes together with chest pain immediately makes most doctors' heads go to heart attack. But jaw pain by itself in a woman with nothing else might not necessarily make your head go there first. So people can experience a number of different symptoms in the run-up to having a heart attack. And sometimes they can be very severe, as in your mother's case. Sometimes they're actually actually surprisingly subtle. And I've certainly had patients say to me, oh, but this couldn't be a heart attack, so I don't feel that bad, which seems a silly thing to say, but it's really words that patients have said to me over and over again. So women come to hospital later. This is a study out of Sweden of people who presented with heart attacks and how long it took them to get to hospital after they first started experiencing the symptoms. And I won't belabor the details, but these are the women in the over 120-minute category. So women tend to show up later. And there was another study which I haven't put graphs in, but it was in Hong Kong looking at time from the first symptom that you might be able to associate with a heart attack to showing up to medical care. And the differences in this study were staggering. Men, on average, presented within about 16 hours. For women, it was somewhere up around 60 hours from the first time they had a symptom to the time they sought medical attention. And there are lots of reasons for that, some of which we've already gone into. They don't think it's them. They don't think this could happen to them. They have other competing interests in their lives that make going to hospital seeking attention, inconvenient. They don't want to be a bother. There's any number of things that might underlie this, but understanding this better will help us look after women better in the future. And doctors have it hard too in this context. As a group of professionals, we're also taught from the traditional checklist that is based on predominantly masculine or typical symptoms. So we think less heart attack when a woman, particularly a young woman, presents because of that training. So we're taught to consider it second. Women don't think of heart disease. Doctors don't always think of heart disease. It is an issue, and doctors do take longer to figure out that a woman is having a heart attack on average than they do for men. Women also have more heart attacks caused by atypical mechanisms. Now, I'm making some very broad generalisations here, but in the majority of heart attacks, in the traditional way of thinking, there's a blockage of the artery due to a build-up of plaque and cholesterol. Women have these heart attacks too. I'm not by any stretch saying they don't, but they are more likely to have some of the less typical types of heart attacks that can be more difficult to diagnose and treat. Women are more likely to have heart attacks that are caused by these tiny, tiny little vessels, not the big ones up here, but these little ones inside the heart. And that can be far more difficult to treat than a blockage in one of the large arteries. Women are also more likely to experience SCAD, which was what was discussed in that video. That's a spontaneous coronary artery dissection, which is where there is a rip in the lining of the arterial wall that then causes narrowing or blockage of the arteries. It can be hard to diagnose. It can be even hard to diagnose when we look directly at the arteries, but it's really important for us to know about it because the treatment is actually different from a traditional heart attack. And in women under the age of 50, this is actually not a rare cause of heart attacks. Not a lot of women under 50 have heart attacks, but when they do, these more unusual causes pop up more often. And women are also more likely to experience stress cardiomyopathy, or also known as broken heart syndrome. This is a condition where the pumping function of the heart is reduced, and it's often associated with emotional stresses. So this bit of the heart should squeeze, pump all the blood out. In this condition, it stops for a period of time. And we don't completely understand the mechanisms of this, except that it's commonly associated with emotional stresses, and it's more common in women. And I'm not sure how this video is going to project. Let's see. Nope. Okay. No luck there. It's all right. And in this case, what we see is that the bottom part of the heart squeezes normally, but the top part doesn't squeeze as robustly, and that's very characteristic of this condition. There are also differences in risk factors and how they behave for men and women. We divide risk factors for heart disease into the sort of traditional ones that are well known and been established for a long time: diabetes, high blood pressure, obesity, cholesterol. And then there are more newer ones that we're learning to understand. And very interestingly, a lot of these cluster around pregnancy. Having high blood pressure in pregnancy, giving birth to a preterm baby, having gestational diabetes. Pregnancy and women's heart health is very, very closely related. I'm going to talk a bit more about that in a moment. But understanding that some of these risk factors are unique to women is very important in our understanding of heart disease going forward. So I'll talk a little bit about traditional risk factors. Diabetes seems to have a bigger impact on women than men. So women with diabetes have a 3-time increased risk of fatal heart attacks compared to non-diabetic women. And the heart attacks occur earlier and with higher mortality in diabetic women compared to men. They also tend to get less invasive procedures and less stents put in their heart. The reasons for that are still to be understood entirely, but there does seem to be some difference in how diabetes impacts women compared to men. High blood pressure is also super important, and women over the age of 60 have more high blood pressure than men, and it's less well controlled on average. So here we have 66.8% of women over the age of 60 with high blood pressure compared to 8.6% of men. At younger ages, there's less high blood pressure in women, but certainly with aging, it does appear to become a really important factor. So what is high blood pressure? Well, the goalposts have shifted a bit on this recently. I remember being at the American conference in 2017 where they changed the number. That was the absolute cutoff for high blood pressure. But generally now, anything over 130 systolic is considered to be high blood pressure. So there's actually a large number of people in the population that have high blood pressure. And in a large number of people, this might be unrecognised because the goals aren't quite as, oh, what have I done? Oh dear. Sorry, excuse my technical incompetence. Here we go. And what we treat varies, and it depends on other risk factors. If you've got normal blood pressure, you're good, but we do need to keep an eye on it and promote healthy lifestyle factors, even if the blood pressure is normal. If it's a little bit elevated, but not in a dangerous level, we often try diet, exercise, other modifiable factors. But as it starts getting higher, we look at implementing pharmacological treatment of various types. And treating blood pressure does help. It reduces your chance of stroke, it reduces your chance of heart attack, and it reduces your chance of heart failure. So implementing treatment in a timely fashion is really important in this population. Cholesterol is also a big issue, and high cholesterol is important in women with heart attacks. It is probably the strongest risk factor for heart disease. And women, oh, sorry, yes?
Oh, sorry. I just have a quick question about blood pressure.
Of course.
What about low blood pressure?
There has been some argument, it's gone back and forward. There are some studies that suggest that it is possible for your blood pressure to be too low. There are also some studies that suggest that we can treat your blood pressure to a lower level. I suppose in terms of if you are a person in the community who runs a low blood pressure, we tend to think that's beneficial rather than a problem, as long as it's not causing you to, say, pass out every time you stand up. Obviously, that's a different issue. But generally, we are pretty happy if our patients have blood pressure on the lower side, as long as it's not causing them symptoms. So cholesterol management's really hard. This is the chart that guides cholesterol management, and I find this confusing, and this is what I do. But I think the take-home message from this is that what we look at is your risk of having heart disease going forward, and use that to guide our decisions about whether you need treatment. One of the really interesting things about the most recent guidelines is that for the first time they include specific to women causes as things that doctors should look at. And this is really new, the inclusion of things like pregnancy factors in guidelines. It's slowly starting, but it's taking its time. So this is one of the first times a major guideline has told us to ask women about their pregnancy history in order to guide their cardiovascular disease. And I think that's really important. And then what is probably the most difficult risk factor, obesity and physical inactivity. It looks like probably probably the effect of obesity and coronary artery disease is more in women than in men. And the prevalence of inactivity and sedentary behaviour is higher among women than men. And this is a big problem for society as a whole, but also for us in looking after women's heart health. We are, as a population and a world, becoming more obese, and obesity levels are rising everywhere. So almost all Western countries surveyed show increasing obesity. The US is the blue line up here, but Australia sits here. England, Canada, all trending the same way. Austria seems to be doing all right. But if you look up here, this is saying that we're expecting 80% of the population to be overweight or obese coming forward. So this sounds a bit ironic to say a big problem, but it is a real issue, and it's probably the risk factor that is hard to do something about. We can't give you a pill to solve this problem.
I have another question.
Yeah.
Sorry. So do you separate being overweight and being obese? Because being overweight, I feel like, I don't know. Yeah, if you answer.
Yes, I mean, yes, it's a very good question. There's a lot of arguments back and forth again. It's a topic of contention about the healthy, overweight individual and being fit, but having a BMI that falls outside of the categories. And BMI is not perfect. It doesn't account for everything. You know, many elite athletes technically have BMIs that wouldn't fall in the healthy category. So I think it's hard to say, you know, absolutely. Certainly there does, across studies, seem to be this relationship that as you get more overweight, things get worse. But I don't think it's possible actually for us to be prescriptive on an individual patient level based on big group data. And I think, you know, although it's always beneficial to be healthy, active, and not have sedentary habits, you know, whether an individual with a BMI of 24.8 is actually healthier than a person with a BMI of 25.2, it's not as simple as that.
Thank you.
But there is some good news. Lifestyle can probably help us fight genetics. We can't fix our genetics. We're born with what we're born with, but making healthy choices can help us reduce the impact of our genetics on life. And this is a study that was done out of this hospital. It was published in the New England Journal of Medicine, and it looked at 3 different cohorts, and it stratified them into how high the genetic risk was. Can't do anything about that. But then also how healthy their lifestyle was. And even if you're in the highest genetic risk category, if your lifestyle's healthy, you can reduce your rate of events. So there is hope. You know, even if you're dealt a bad hand in the genetic lottery, you can still improve your chances of running into problems with heart disease.
What's the Malmo diet? Okay.
Sorry?
And the third column on the right,
Yeah.
C, it says Malmo, M-A-L-M-O with umlaut above it.
Oh, yes.
What is that?
I can't tell you the details of the diet itself. This data was drawn from a large study of diet and cancer, and it was just used as a cohort in this study to prove that the relationship holds across lots of different groups. I'm sorry, the exact details of a Malmo diet, I am ignorant of.
Never heard of it, so.
And real-world women face real-world barriers. This is back from that study that looked at how many women would call 911 if they thought they were having a heart attack. And it looked at things that would make life difficult to lead a healthy lifestyle. And there is confusion in the media about what to do. And there are real-world family obligations and other things that women have to do. And it's not easy. Everyone knows that it would be great if we could all get out and get our, 30 minutes of exercise a day. I haven't got 30 minutes of exercise one day this week. So, it's easy to say, hard to do, but part of our job is to help people work out how we can do this in a way that fits in with their lifestyle. Now, I'm going to try and be brief on this because, honestly, if you got me started, I could talk about this subject all day. But pregnancy is related to women's heart health, and we are learning more and more about it every day. And this is from a paper that one of my colleagues published at the end of last year. And it looks at if you've had high blood pressure during your pregnancy, what is the risk of you having heart disease in later life? And it turns out there is a relationship.
Can I ask, on the mitral, what is the mitral regurgitation? What is that?
That's a leaking heart valve, one of your heart valves being leaky. And this is actually one of the most interesting things of this study. We've sort of known for quite a while that having high blood pressure during pregnancy is associated with maybe having more heart attacks, but no one's ever actually known until this study was published that you might have more valve heart problems as well.
How do you know you have it?
Generally, we diagnose it by doing an ultrasound of the heart, an echocardiogram. If it's a severely leaky heart valve, people can get symptoms like shortness of breath or difficulty exercising or exerting themselves. If it's subtle, people may not know they have it unless their doctor hears a murmur when they're listening to their chest. That's a common reason that we do the ultrasounds and find it. So yeah, we've discovered for the first time that we might have valve disease problems if you've had high blood pressure in pregnancy, and that's very interesting, and it's something that we're working to understand better. Having a preterm birth puts you at higher risk of having heart disease. So if you have a pregnancy and your child is born before 37 weeks, there is some association of that with future heart health. We don't really understand 100% why this should be the case. There's lots of theories out there. People are still learning to understand it. But the relationship is there and has been proven on in big studies looking at lots and lots of women. If you've got diabetes during pregnancy, then you have both about a 7.5 time increased chance of having diabetes in the future, so going on to have type 2 diabetes, but you also have an increased risk of heart disease. So these are all the studies to date that have looked at gestational diabetes versus no gestational diabetes, and simplifying the statistics, the summary falls on this side of the line, which means women with gestational diabetes have a higher risk of heart disease going forward. And I'll touch briefly on HRT because it's a subject that has had many words said about it in the cardiac sort of arena, and certainly something that we not infrequently get asked about our patients. The literature on HRT and heart disease has, as this graph shows, gone up and down, and lots of different opinions have been had. Back in the sort of 90s, people thought, well, women start having their heart attacks later than men, and premenopausal women don't have a lot of heart attacks, so surely hormones are the answer. If we give everyone hormones, it will improve their heart disease. And then in the mid sort of 2000s, a couple of really big studies were published that showed that actually this wasn't the case. And this actually had a really big impact on how hormone replacement therapy was prescribed. Since then, things have shifted a little bit back in the other direction, and people have started looking at the nuances of those studies, you know, how far post-menopause the women were, how much hormone they were given. But still, actually, the take-home message today is that HRT is good in women who don't have a contraindication to it for the treatment of menopausal symptoms, but it's not for preventing heart disease in women. It shouldn't be used for that purpose. So I've spoken a bit about pregnancy already, but pregnancy is really interesting and a unique time to look at cardiac disease in women and cardiac risk in women, and also a time to potentially intervene to help women's health in the future. And one of the really unique things about this is young women and young people in general don't spend a lot of time hanging out with doctors for obvious reasons. But pregnancy is a time where young women and otherwise healthy young women get seen regularly in a medical context. And so it's actually potentially a time where we can start instilling healthy behaviours going forward, and also identify women who are potentially at higher risk and that need to be looked at more closely. And pregnancy is a stress test for your body. During pregnancy, there's a lot of changes in the body, in the cardiac system. Your heart rate changes, your blood pressure changes, your blood volume changes. So this can unmask a lot of potential, I suppose, vulnerabilities in a woman. And what we don't know, and causes some debate back and forward amongst people who work in this area, is whether pregnancy does something to the woman that increases risk, or whether the risk was always there and pregnancy just unmasks it. And that's a very difficult question to answer. But regardless of which way it is a time where we can find this out about women potentially. And unfortunately, maternal mortality in the United States is rising and has risen over the last period of time. And cardiovascular disease is the predominant player in this space. So this is from the CDC. It looks at all the causes of maternal mortality. And if you look over here, heart, there's a lot of cardiac diseases in this place. There's also some conditions that happen to women relating to their heart just around the time of pregnancy. This is a very busy slide, but some of the conditions that uniquely present in women around the time of pregnancy is a very specific form of spontaneous coronary artery dissection called pregnancy-associated spontaneous coronary artery dissection, which can happen around the time of delivery. And obviously, a large heart attack in a woman who's just had a baby or is about to have a baby is a very big deal. And also peripartum cardiomyopathy, which is a condition associated with pregnancy where the heart muscle becomes weakened for reasons we don't understand. And these women present with heart failure around the time that they have, around the time of delivery normally. And it's very difficult to look after pregnant women and women who have just given birth with heart conditions. There's obviously need to weigh treatments that we know are safe in people who aren't pregnant, aren't necessarily safe in pregnancy, and we need to change how things are done. Sometimes we have to change the way women are delivered because of their heart issues. And the options that we use in the regular population of popping a stent in involve radiation exposure and are also not necessarily a good idea for pregnant women. So it is a very specific area. Very lucky here at MGH to have the Women's Heart Service, who are very experienced in dealing with women with high-risk pregnancy conditions, but it's a potentially very difficult situation. So I want to have time to take questions, but I hope that I've convinced you that there are some differences between the way heart disease behaves in women and in men. Women present differently. Our risk factors are not exactly the same as men's. Sometimes we might have different types of heart attacks, and pregnancy plays a big factor both in our risk of heart disease, in revealing heart disease, and making challenges in management of heart disease. We're still learning how to optimally detect and treat heart disease in women, and although I don't have a slide, one of the things that comes up is a lot of our background knowledge about things that are good for heart disease. Most of the people in those studies were men. So we think that these things are just as good in women, but we don't always know. And once I was giving a talk on this to a bunch of medical students, I went back to look at the first paper that showed that aspirin was a good idea in heart attacks. What? Aspirin. So just taking an aspirin was a good idea for a heart attack. That idea's been around for a while. I realised that the paper was published so long ago that they didn't even include the number of women who were in the study. It wasn't even thought to be important to list gender. Presumably, most people in that study were men because those are the people who get recruited predominantly to studies on heart disease. So, you know, we are learning more and growing more in our understanding of this field, but there is still a way to go. Happily, here at MGH, we're very lucky. We have a very strong women's heart health program, and I'm very lucky to have the opportunity to work with them and be here and hopefully help try and get the message out a bit. So thank you all for being here, and please feel free to ask any questions.
I have a couple of questions.
Yes, please.
The first question, what are the symptoms of blocked carotid arteries?
Blocked carotid arteries. So the carotid arteries cause arteries in the neck that supply blood to the brain. So if you get narrowing of those arteries, actually you might not have any symptoms at all. It could just be narrowed and you might not know about it. The symptoms it can cause essentially relate to stroke. So if you're not getting enough blood flow up to your brain, a stroke is the outcome. Now that can be a small stroke or a large stroke depending on what happens. Sometimes people will get some transient symptoms if the blockage is tight enough and their blood pressure, say, changes, goes up or down. but it can be anywhere on that spectrum.
So carotid arteries aren't something that's normally checked in a person as part of normal preventive maintenance?
It's not generally routine screening done in that area, unless there's specific symptoms that lead us to think that a person might have an issue in that area.
Okay, and the second question is, people sometimes get aortic aneurysms, they don't know if they have it, so
Yes.
as a cardiologist, is that something you would know from doing different tests?
It's certainly something we can detect on testing. There are certain people who fit into categories of us thinking that they're at higher risk of having an aortic aneurysm or not. I suppose there's two types of aortic aneurysms. As a cardiologist, I generally deal with the ones in the chest, and we can detect that on an ultrasound test of the heart. Sometimes we'll also do a CT scan of the heart. You can also get aneurysms in the stomach, in the descending aorta. We can sometimes feel those if we're examining the tummy, and there has been some arguments for doing a single screening look at the abdomen once in sort of later life.
So you're saying a cardiologist won't be the responsible specialist for the stomach aneurysms?
I might actually have to ask my colleague Daniela about that, because it differs a bit in Australia compared to here as to what specialty does what. At home, we would not look after abdominal aortic aneurysms, but Dr. Cruciat, can you enlighten me as to the state here?
I would say for the most part, it depends. There's some patients that have both chest and also abdominal aneurysms. In that case, we're involved. Sometimes these patients are seen by vascular surgery. These are essentially physicians or vascular medicine. They're either doctors or surgeons that are that essentially that is their specialty of choice. Essentially, vascular just means any kind of vessel in the body.
But I've never heard of a vascular specialist. I've heard of vascular surgeons. Are there vascular
There are
specialists?
vascular non-surgeons who also see these kinds of things, and they tend to be cardiologists here in the U.S. So people who are cardiologists who then choose to kind of just specialize in the vascular system.
Oh, so they're cardiologists.
Yeah, they tend to be cardiologists, but not all of them. But they are specialized in just sort of the vessels. They would deal with the kinds of things you're talking about, whether it be the carotids as well as you first discussed, or also any kind of aortic or kind of belly vessel problems.
So if I went on the national website, I wouldn't see a specialty called vascular general.
You should. It would be vascular medicine.
Okay.
Which is separate from vascular surgery. And I would say they collaborate and they work very closely together. And they also, some of them are fit under the umbrella of cardiology. That's a good question though.
Okay, because I've never seen those, so thanks.
How about the shortness of breath? Like if you climb a mountain or you get shortness of breath, but how serious when it is become?
Yeah, that's an excellent question, and it's one that doesn't have a simple answer. Some of it relates to how fit you are. If a marathon runner gets out of breath at the end of the marathon, that's probably okay. Can I apply the same standards to that person as to what abnormal shortness of breath compared to, an elderly person who doesn't do much? The answer is no. We have some arbitrary tests we use. We ask people if they can climb 2 flights of stairs. We ask people if they can walk around a shopping centre without getting out of breath. But it is individual, and what's often more important is a change from that person's baseline rather than an absolute value.
What about walking up a hill?
Again, yes, we would often be interested in, say, can you walk up? And again, it's arbitrary. What I normally ask my patients is it different to what you could do 6 months ago? And that's not a perfect test. We all do slightly less in winter, slightly more in summer. But that is what gives me an idea of, are things changing for this individual person? If I run up 10 flights of stairs, I'm out of breath. If I start getting out of breath at 1 flight of stairs, I'm going to start getting worried about myself. It's sort of that relationship that we tend to rely on.
What about the value of vitamin supplements like magnesium with arrhythmia, things like that? Do you find those to be helpful?
There are specific circumstances where a certain electrolyte in the blood is at a level that we're not happy with, where there's definitely evidence of us giving that in that context. I think vitamin supplements overall are a challenging and controversial issue. There have been studies suggesting some of them are beneficial under some circumstances, and also studies suggesting that they may not have as much impact. On an individual level, for example, with magnesium, in patients who have atrial fibrillation where their magnesium is low, certainly supplementing magnesium can be helpful. After operations, we watch for magnesium levels because people whose levels are low might have more arrhythmias. But whether we're giving everyone in the population magnesium would reduce overall the population's level of funny heart rhythms, I don't think we know the answer to that.
You said that women are not diagnosed as quickly as men who have heart disease. Does that number change if the woman is a doctor, the doctor is a woman?
Actually, there is a bit of evidence on this. There is some evidence that suggests that women do better after heart attacks if their doctor is a woman, and that gender concordance probably has beneficial effects in terms of treating women's health. I'm not aware of any data that specifically looked at like time to diagnosis if the doctor is a woman or not. But I think honestly, overall, men, women, regardless of what gender your doctor is, it's about awareness. If you're not thinking, you're never going to find the answer. If I go and see a patient and think this is a young woman, you know, she's not going to be having a heart attack, then I'm never going to diagnose that woman's heart attack. There is some evidence, and again, it's getting a little bit old now, that women who present with symptoms of heart attack actually are more likely to be sent home. The absolute number was very small. Most people who present with symptoms of heart attacks, male or female, get admitted. But this was a specific study looking at people whose heart attacks got missed for whatever reason, and women were slightly more likely to fall into that category. But again, we don't know anything about the gender of their doctors in that instance.
One more question. What's the scoop on 81 milligram aspirin now?
Ooh, depends on context. That's a very challenging question. Certainly in people who've had traditional heart attacks, as in had a heart attack, had a stent-blocked artery, we know that it's very beneficial. Its benefit for primary prevention, as in stopping you from having heart attacks, is very individual patient specific, and is based on a balance of the risks of you having something go wrong from the aspirin, i.e. having a bleed, and the benefits that the aspirin will provide you. So if I'm having that conversation with my patients, it's very much an individual risk factor discussion.
How do you distinguish like heartburn-like symptoms? Like, you know, you can experience heartburn from like eating spicy food or something. But how do you distinguish that from symptoms like the tight chest pains of having a heart attack?
It's really hard.
Sometimes like I will get like heartburn and I'm like, I think this is heartburn, I don't know. And then it goes away super fast and I'm like, okay. But it's happened to me like twice.
Yeah, it's an excellent question, and I've got to tell you, the number of patients I've seen who've had heart attacks and then come back and are like, well, I used to think this was my heartburn and now I don't know, and they're not having another heart attack, and they go, well, how can I ever know? And it is really hard. We have to say to them, you know, it's probably a combination of things. If I got heartburn today, I would think it was heartburn. I would not. I'm a cardiologist, I like women's health, but I would not think I was having a heart attack. Would I be right or wrong? Who knows? But I think things that would make us worried are having other symptoms along with it, and symptoms that persist. But certainly if you're getting a lot of episodes of something that could be, it's better to get checked out than not. The consequences of not getting checked out are certainly worse than the consequences of getting checked out.
Can you tell when you do your blood pressure if it exceeds a certain amount, the pulse, and it's very high? Would that be a possibility of a heart attack?
Look, actually blood pressure during heart attacks can either go up or down depending on the type of heart attack. Certainly there are certain types of heart attacks that are associated with high blood pressure. I would think if your blood pressure was highly elevated on an ongoing basis, regardless of whether or not you were getting chest pain at the time, it needs to be sorted out. Yes, I don't know who's next. You know.
If you have a family history of heart disease, should you get a cardiologist on board before something goes drastically wrong so you know who you're getting, rather than wait till maybe you have a heart attack and then you just, go to the emergency room?
I think it's always really important to be educated and educate yourself on your risk. So I think, you know, if you do have a lot of risk factors in either yourself or in your family history, it's never hurtful to have the conversation. Again, some of the idiosyncrasies of the US health system are not, I'm not the best person to explain that, and the way the Australian health system works from that basis is a bit different. But I think, you know, our job would be best if we could stop people from having heart attacks by modifying their risk factors before they had the heart attacks. So there's never a bad time to have that conversation.
Alright, so I just have a question from our live stream.
Yes.
But in terms of diets, is one type best? Like for instance, the low fat, Mediterranean versus keto, or low carb?
Ooh, that is a really challenging question. Again, the evidence varies, and that makes it a hard question to answer. Generally, you know, what has been the overall finding is that maintaining a healthy weight and healthy lifestyle is beneficial. The individual idiosyncrasies of certain diets, and certainly, you know, there has been some concern, I can't quote the data to you, that some of the diets that emphasise high fat, low carb might have bad effects, but I don't think we have the outcome data. So I think the overall message is more about a healthy diet and moderate diet, and certainly that's what the American Heart Association would suggest, and the Australian Heart Association, balanced eating and healthy lifestyle rather than one particular diet over another. Yes, sir.
I recently bought a easy-to-use EKG monitor off Amazon for about $100. What's your view of use of that kind of monitor to give more advanced warning of heart issues?
Look, I must admit I'm not familiar with brands, so I couldn't probably comment on that individual brand. I think what's really powerful and really interesting in the modern world is how much more information about ourselves we're all getting. I mean, Apple Watch knows so much about all of our heart rates and our activity patterns. And I think one of the challenges going forward is how we leverage that information, how we best use all of this technology that's available. And I certainly have had patients who have apps on their phones where they can put 2 fingers on and get an ECG, or an EKG, sorry, and send it through to their cardiologist. I think it's certainly that I found helpful in certain situations, more in terms of arrhythmia monitoring, so funny heart rhythm monitoring than diagnosing ischemia. But, you know, I think this is only going to grow. More of us are going to have these things at home, and the challenge for us is how we integrate that into our practice and in a way to help you the best from that knowledge. Have I exhausted everyone? Well, thank you all. Thanks so much for the opportunity.